Hello, Dr. Triplitt. Thanks so much for joining us. Dr. Triplitt is currently an associate professor of medicine at the University of Texas Health at San Antonio. He is actively involved with research, clinical, and the education of people with diabetes and healthcare professionals training at the Texas Diabetes Institute in San Antonio. So Dr. Triplitt's going to join us now and do his presentation.
All right, so I'm pushing to the presentation. I'm assuming I'm gonna share now, correct?
Yeah, and make sure you select at the bottom of the share box to optimize your sound from your computer. The two little check boxes in the share box, you're going to see at the bottom of it.
There we go.
Yeah, share computer sound and whatever the other one was, and it will make it much better, I have learned.
Are you able to see it?
Yes, perfectly. And I'm going to stop my video now and just focus on you.
Okay. Well, hey, I want to just thank you guys so much for allowing me to come to you guys to talk tonight. Certainly is my pleasure, and I know in these extraordinary times, all these things come together to make us go, hey, I can't believe we're having a meeting virtually, but I truly think that this is going to be the future for a lot of different things because of the fact that the interactivity is incredible. So thank you to the JDRF, of course, thank you to all their sponsors. And of course, today I have to thank Xeris too, because Xeris is one of the ones that have allowed me to come and talk to you tonight. So one of the things that we're going to do is we're going to explore a situation that none of us ever really want to happen. But as they say, preparation is half the victory. And so tonight what we're going to be talking about is ways of preparing for some situations which we hope we never happen. And of course, that leads us down in the know to conversations about severe low blood sugar and treatment options. The first thing I want to do is to explain to you guys that even though we're virtual, we'll still be interactive in some ways. So I want you guys to look closely here. First of all, what it is you can either go to the pollev.com. And if you go to pollev.com, what you can see is that pollev.com, which you can, I'm going to go back here. Apologies. pollev.com, what you're going to see here is that you can actually answer these questions I'm going to give you. The other way of doing it is text hypo to 22333, and that's going to enter you into the system to answer the questions. Now, you go, well, what happens when I enter my number or this website? Nothing. They're not keeping track of you. They're not going to handle your number for later or anything like this. This is completely just an educational poll for us to be more interactive in this virtual way of doing it. So I'm going to give you just a second to text in or to log in and do that particular information, because the next step is we're going to do a sample question. The other thing to remember is that while you're doing that, I want to remind you that unfortunately, this talk is on label. And what that means is that I am bound by the rules of the FDA to tell you certain things and to not tell you certain things. And so I do want you to be understanding of this particular point. As Tammy had mentioned, if there's questions that you want answered offline that I unfortunately can't answer, I'm going to email you back. I'm going to try to answer your question to the best of my ability. If I can't answer it, I will tell you that, because right now I'm talking to so many people that you never know who's listening. And
Dr. Triplitt?
Yes.
Can you turn up your volume on your computer?
Is that better?
That's much better. Thank you.
Okay, you bet. So let's go to the question and see if this is going to work out for us, okay? All right. Oh, you guys, look at you. You're already there. So what we're asking here is, how many years have you had diabetes, or if a caregiver, how long has the person you've been caring for been diagnosed with diabetes? And what you're seeing here is you're literally seeing the numbers coming in as we speak. Is A, so you type in the letter A. If you're on text, it would be that you're newly diagnosed less than 1 year. If you type in B, 1 year to 2 years, C, 2 to 5 years, D, 5 to 10 years, or E, 10 years. If you just simply put in E and put it in, it will actually come up on your screen. And what you're seeing in real time is that we have most of you either are a caregiver or a person with diabetes for more than 10 years. And that's not surprising with us. So as you can see, we're actually getting a nice number of people coming in and out. So one of the things I like to do is kind of get a feel for who's in the audience as we do this. So that's one of the things I'm doing right now. So the other thing to think about is as we move on, and that's what I'm going to do right now is move on past this poll, is to think about what situations we're in where this would be appropriate. So I'm going to just tell you a little bit about Tom. So remember, we've all had these people that we've interacted with. This happens to be someone who is a real person, but interacted a little bit. And so Tom was a 25-year-old person with type 1 diabetes, and he and his fiance were out on a bike ride. He had a CGM, so he was pretty in the know, and he was riding along, and all of a sudden he felt funny, and he checked his sugar. It was 45, but he noticed the CGM arrows, as you guys know, were going down. And so he ate his carbohydrates. In this case, he had Skittles and raisins. When he got to the end of that, the sugar was still going down. Of course, at that point, everyone started to be a little more worried. And then what happened was that they were able to go to a local convenience store, and the fiance got more. When the fiance got more carbohydrates, she came back. By that time, his glucose was 26. He was able at that time to actually take in more carbohydrate from multiple sources, and his sugar thankfully started to come back up. And when they retested it, the CGM showed it was going up. So the thing about this is he was really in survival mode. And it's one of those situations you go, well, we're talking about glucagon today. Was glucagon appropriate for Tom? The answer is a little more complicated, and really we have to get a little more deep into it. And we're going to talk about that as we go through the presentation tonight. So the next question I have for you guys is, how often does someone with type 1 diabetes experience a severe low blood sugar episode on average? Is it A, rare, less than one episode every 10 years? Is it B, one episode every 5 years? C, one episode per year? Or is it D, one episode per month? Well, interestingly enough, most of you are choosing D. So that does mean that we have a group of people who have had diabetes for a while, as you had said before. And one of the things we want to do is make sure that we talk about this a little bit more. And I'm going to give you the answer on the next slide, so we might as well switch. So what are we talking about? Well, actually what we're doing is we're talking about severe lows happening maybe in about one episode per year in general. So severe lows happen not only in type 1 diabetes, but can also occur in type 2 diabetes, especially in people on insulin or on certain oral medications such as sulfonylureas, which help us to actually release insulin from our pancreas. Obviously, in type 1s, we take insulin, and that's why we're at higher risk for hypoglycemia, because the insulin cannot stop. It simply does its job. It lowers sugar. If it does its job too well, we can have a low blood sugar reaction. So again, in most studies that have been shown, around 3 or 4 out of 10 people are having 1 to 3 severe lows per year. What that means in type 1 diabetes is the fact that we're literally talking about maybe a smaller proportion of people having a higher risk. And so our main thing is that we need to, one, address how we're going to overcome these barriers. And number two, we need to see how we can quickly treat that, because severe hypoglycemia has potentially severe consequences. And we'll talk more about that as we talk about the pathophysiology and some of these other things that we like to talk about for hypoglycemia. Now, an important and surprising point is the fact that we actually know that most people who are at higher risk of having hypoglycemic reaction have strict glycemic control, or as you guys were saying, about 2/3 of you said you actually were had diabetes for more than 10 years. So the biggest two factors were duration of diabetes and how strict a glycemic control you had. And in our current situation, we're asking for most people to have an A1C minimally less than 7, unless there's something else going on. obviously someone, if you look at this slide, says a hemoglobin A1C less than 7% made the person have a higher risk of severe hypoglycemia. But it wasn't the only people that were at risk. As you see, from 7 to 8 to 9, there was still a risk. And so that becomes a little more interesting about how is it that people who even have an A1C of 9% can be at risk of a severe hypoglycemic reaction? And the answer is we're going to go over some of the factors, and you'll see if someone makes a big mistake, sometimes even if you have a hemoglobin A1C of 9%, which would mean your sugar is over 200 maybe, you would still potentially have a higher risk. All right. So the other thing that we don't talk about much, and this is something that Dr. Polanski talks about a lot, if you know who I'm speaking about, he talks a lot about the fact that this is such a worrisome thing to people with diabetes. Once you've had one, it's such a debilitating thing that once you've had some low blood sugars in the future, you worry about them. Now, when we're just human beings, so what happens is that a lot of times when we have a low blood sugar, we say, well, I would like to avoid that in the future. And sometimes what that means is that we literally avoid it by having our sugars run higher. And about 2/3 to maybe even 84% in type 2 diabetes would say, I fear having a hypoglycemic reaction in the future. That is a logical reaction, okay? When you've had low blood sugars, you realize they're not fun and they can be debilitating. But I also want to remind the people with diabetes listening that perhaps beside you right now, or even listening as the primary person, is a caretaker of a person with diabetes. And caretakers have the same kinds of fears, that they're going to be put in situations, or their loved ones going to be put in situations where they're not there to help, or when they're in situations where they need the help, and people who are not as skilled as them are going to have to take care of you or the person that you love. So we need to make sure that in those situations that we try to make these treatment options very easy to use. Which brings us to our next poll everywhere question. What is glucagon? Is it A, an injected form of glucose? Is it B, a hormone released by the liver that lowers blood glucose levels? Is it C, a hormone that works to raise blood glucose levels? Is it D, none of the above, or E, the one that helps you? I'm not sure. Very good. So we have a very learned audience tonight. Congratulations. We're upwards of almost 75. So 3 out of 4 people are understanding that glucagon is a hormone that helps to raise blood glucose. So this is important because if you said it's an injected form of glucose, we're going to talk about all these different things. That was the second most common answer. So the natural hormones of glucagon and insulin work in our body. So if you have type 1, you take insulin. The insulin may be modified, but it's still a natural hormone. And you can see on the screen that what happens is when your sugar goes up, we want to take insulin, and insulin helps to bring the sugar back down. That's what insulin's job is. Insulin helps suck up sugar into cells, and also it goes to the liver, and it tells the liver, don't make so much sugar so I don't have to cover as much. But as our sugar comes down, what happens is when it starts going towards normal, glucagon kicks in, and glucagon is released from the same pancreas that insulin is released from. Of course, in type 1, we know that you're taking it in an injection. But in people without diabetes, what you're seeing is glucagon kicks in, and it helps to keep your sugar from going too low. Now, what we do in emergency situations, of course, is we give that hormone glucagon to help the body get over the low blood sugar. Let's look about this a little bit more. This is a little more fun slide, and what you're seeing is that literally these work in tandem, the yin and yang of the pancreas. So what's happening is as your sugar goes up, we want insulin around to bring your sugar back towards normal. But as your sugar starts to decrease towards normal, and I use sugar and glucose interchangeably as a simple term, remember that glucagon will start to be released. Now, in type 1 diabetes, of course, we don't make insulin. In type 2 diabetes, there's a relative deficiency in insulin. In type 1 diabetes, there's really no problem with glucagon. Type 2 diabetes, they actually have a little bit too much glucagon. Bottom line is that insulin kind of acts as the brake. Like on
Hey, Dr. Triplitt, I'm
Yeah.
sorry. We just had a couple more people say that they can't hear you. So if you could just talk super loudly.
Sure, I turn it up as much as I can. I'll
Okay.
talk you. Is this better? If I
Yeah,
talk even louder?
now I can hear you
Sure.
loudly. If
That's great.
I will let you know if they tell me again that they can't.
Yeah, please do. Sorry that that's happening.
That's
So-
okay.
So insulin acts as the brake, kind of like on your car. So when you push on the brake, things slow down, your glucose would come down because insulin is bringing it down. And of course, glucagon is acting kind of like the gas pedal. So you press on the gas pedal, you expect something to go. It's putting more energy into the system. That's what glucagon is doing for us. Glucagon is literally helping you put more energy in the system in the form of glucose. So that's how this system works. In a severe low blood sugar, what's happening is that we're giving the body the ability to release more glucose. Now, during low blood sugar episodes, what happens is that when your sugar is mildly low, you can have some symptoms, some shaking, maybe your heart pumps a little bit, you feel sweaty, hungry, and this is called mild hypoglycemia. And appropriately, when we talk about this, we usually tell people about the 15-15 rule. And if you're not familiar, talk to your diabetes educators. But in brief, we want you to take in 15 grams of a fast-acting carbohydrate and then recheck your sugar in 15 minutes, or in a CGM, you can see if it's coming back up. That would be in mild hypoglycemia, which is somewhere between 50, 40, 70 milligrams per deciliter. They call this level 1. The other thing to remember is that if it's below 54, you can start to have some other symptoms. So especially when it's severely low, you can see behavioral changes. This can go as far as dizziness, confusion, tremors, blurred or double vision. And even if it's very severe, if you get to severe low blood sugar, you can see loss of consciousness. Anytime someone cannot take in oral carbohydrate or actually needs or is unconscious, that would be someone who would be a candidate to take a glucagon. And we'll talk more about this as we move along. Now, here are all the things that can affect your glucose. And this is why some people, even with a high sugar, are at risk. So remember that if someone is sedentary, but then does a much more intense physical activity, and you go, well, that could just be simply that the person goes to an adventure park, or they go to Disneyland, or they're walking around the mall for a few hours when they normally would be very sedentary. That's enough activity for someone, even with a high glucose, to potentially go low. Remember, they skip a meal because they were out and about and they didn't eat. Erratic schedules, stress. It could be things such as management-related factors. Perhaps the pump had an error. Perhaps they used two insulins or used the wrong insulin. And even individual factors, such as people who are a little older, they don't have the same brisk response in those hormones as people who are younger. Also, what happens, of course, is in type 1 diabetes, as you guys know, sometimes you can take a half a unit of insulin and your sugar will go down 60, 80 milligrams per deciliter. Sometimes you take that half unit, maybe some people it only goes down 20 milligrams per deciliter. So that's why we have to be cognizant of that all the time. The fact that all these different factors can sometimes come together in the perfect bad storm in order for you to be at risk of a severe low. Okay, so let's go ahead and answer this question. So when should glucagon be administered? When the person is passed out, A. When the person is having a seizure, B. If the person is unable or unwilling to take carbohydrates by mouth, C. If the person is unresponsive, D. E is only the first two, or F is all of the above. Well, I think this one of you guys, we've been talking a little bit about it. So 4 out of 5 of you have this correct. When the person passes out, because they can no longer take oral carbohydrates, they need glucagon. When the person is having a seizure, that usually means the person is passing out, they need glucagon. If the person is unable or unwilling to take carbohydrates by mouth, this is the one that confuses people. What that says is when you get to the point where the person is no longer cooperative, when the person you don't want them to choke. That's one of the biggest risks of trying to give people oral things when they can't really swallow well, when the sugar is so low. So what happens is that we have to realize that when it gets that low, that they could be a candidate for glucagon too. If the person is unresponsive, that's the same thing. So very good. Most of you are actually on track with WAP. So just to reiterate that and to re-emphasize that, unable, unresponsive, unwilling, unable to take safe in carbohydrates, and that could be at any glucose. So though we like to say, oh, if the sugar is below 54 milligrams per deciliter, the answer is if the sugar is 55, 60, and the person can't take in oral carbohydrates, glucagon is appropriate. Unresponsive, the person can't answer basic questions, is being irritated, they're not thinking correctly, or they're having symptoms that you think they might pass out, or unwilling. And that means a lot of times people get combative or confused, as we were just mentioning. Now, there are a lot of different products on the market, and one of those is the tried and true glucagon injection kit, which is still out there. We're not trying to tell you this kit will not work. That is absolutely not true. What we are trying to tell you is that this glucagon injection kit is one of the reasons why many people feel uncomfortable with this situation. So what happens is the fact that it has to be put into this complex form because glucagon is a very unstable hormone. What happens is that if you put it with water, it will degrade almost immediately. Even we in research, I do research in diabetes, we have to use special stabilizers for glucagon to keep it from degrading once we draw blood from people in research. And this is true if you actually go and get blood drawn for glucagon. So we have to be very careful with glucagon because it's so unstable. This has always been the problem, and that's why there's two different. There's the glucagon, and then there's the diluent. Now, the problem goes with all the steps. You see currently what I'm showing you on your slide is 9 different steps that have to be done in order for this to happen. In many of the studies that have looked at this, about 4 out of 5 people who attempted it did something wrong. Now, that doesn't mean that they always weren't able to get it in, but some of these steps are extremely important and put the person at higher risk. One of the most common things that happens is the fact that they had difficulty in mixing. So when you put the water into the diluent, it doesn't always go into solution right away, but because you feel anxious, you pull it back out, it's not the full dose and you inject it. Another thing that's happened, I've heard about this personally, is the fact that the person took it out, said, well, here's the injectable, did not use the little vial because they couldn't figure out what it was and just injected the placebo. So we have to remember there is still education that has to go on with this. But remember, we're talking about how can we simplify the process. So just as a mini review, glucagon is something you needed to have on hand to be prepared. It's half the battle to be prepared. It is the one product I and most of the people listening hope you will never have to use. We hope that what happens is that you get a glucagon kit, it expires, you get another one, it expires, you get another one, it expires. You never have to use it. But preparation is half the victory. So we have to prepare for the potential thing that could happen. Remember also, in the story, it doesn't work if you don't have it with you. So Tom did not have his glucagon with him, but he did have glucagon. It was at home, which means it didn't help Tom at all. So we must keep the glucagon close to us and on us at all times in order for it to be a potential saving medication. So again, carbohydrates with you at all time, fast acting, and your glucagon injection. People who take insulin injections are at higher risk. People who, and that's true whether it's type 1 or type 2. Glucagon will raise your sugar if your sugar is low. So today what we're talking about is a simple process. This is called GVOKE. It's a glucagon injection, and it's a pre-filled syringe that already has the glucagon in solution. It's pre-mixed and it's pre-measured. And what that means is that literally what you do is it's a 2-step process, and at the end of the 2-step process, the glucagon is injected, unlike the 9 or 10 steps I showed you before. So if we talk about this just a little bit more, what you're seeing here is GVOKE, as we call it, is just under 4 inches long, It comes with a very tiny needle. It's subcutaneous. So a lot of times the other ones, one of the things that happened was that because it actually can be giving subcutaneous or into the muscle, sometimes people even broke the needle off in the person because they were being so aggressive, because it's a very panicky situation. So again, this is subcutaneous. And what happens is that it's 27 gauge needle and it comes in a pouch. And you don't have to open the pouch until sometimes, hopefully you never have to open the pouch. But if you do, you don't open it until you're going to use it. And in usability studies, what they found is because it's so simple that 99% of the people are actually able to use it without problems. And that means we simply told them once, do this, two-step process. 99% of the people were able to do that on return when they came back and say a week. That's very important to understand. So we're just trying to make this delivery simple. Here are the 2 steps you need. You take it out of the pouch, you pull off the needle cap, and then you basically insert the needle at a 90-degree angle, even if you're skinny, even if you're a child, 90-degree angle, and you push the plunger to inject. It is recommended in the lower abdomen, the thigh, or the upper arm. And in an emergency, one of the things I tell you is it's better to get it in than not. Also remember that glucagon doesn't act immediately. It can take up to 15 minutes for these kind of effects to happen. So when you're getting to the point where the person is close to feeling it, we need to start thinking about glucagon, because it's still going to be around 15 minutes to get some of that full effect of the medication. And we'll talk a little bit more about this as we go along. The dosing is very simple. It's approved for ages 2 to adult. If you're an adult or a child who weighs 100 pounds or more, you would take the blue one, which is a 1 milligram. That would be the dose. If you weigh less than 100 pounds, then you would take the red one, which is a 0.5 milligram. Now, the other thing to remember about this versus the other glucagon way that was done before is the amount in here is a much smaller amount. It's only 0.1 to 0.2 milliliters as opposed to a full milliliter of solution to inject. So we just have to remember that it's a very small amount to inject. So we want to make sure we put the needle in and then inject. Now, the next thing a lot of people have told me is, oh, well, how effective is it? Well, we need to remember that we have about 100% treatment success if you look at increasing glucose greater than 25 milligrams per deciliter in children and 99% in adults, and that means in about 15 minutes. The other thing to remember, and a lot of people are worried about, is they say, well, I'm worried that I take that and it's going to raise my sugar so high I'm at risk of diabetic ketoacidosis, or that I'm going to have to cover it later. And the answer is the average maximum glucose in the studies was somewhere between about 130, 120 to about 180. And what that means is that even though you're giving the glucagon, it didn't raise the sugar so high in a hypoglycemic reaction that the person said, oh my gosh, now I have to cover it with insulin. It just didn't happen. All medications have side effects. All glucagons have side effects. For GVOKE, what happens is that glucagon is a hormone that raises sugar, but it does it in a way that actually causes nausea in some patients, even low sugar, and sometimes even vomiting. So the first thing we tell you, if you give an injection of glucagon, make sure if the person is passed out, you push them to their side, because if they get nauseous and vomit, you don't want them to aspirate some of those things back in. The other thing is some of them people will get headaches. Small number of people will have quote unquote hyperglycemia. Some people get a little abdominal pain, a little injection site reactions. But let's be clear, about 83% of these were mild. All of them were in the categories of mild or moderate. And I know that's a technical term, but what it means is that there were no severe bad reactions in people. So
Dr.
if you
Triplitt,
yeah, go ahead.
this is just a warning to you. We're just about running out of time, and I want to get to a few questions.
Yeah, I need to do the safety information and then I'll get to it, okay?
You got it.
So this is the last slide I have to do. So GVOKE is so this is one of those I have to talk to you about. It's the important safety information. So GVOKE is a prescription medicine to treat low blood sugars. Do not use GVOKE if you have a tumor. And this is technical stuff. I'm sorry, but I have to read it. It's part of the ways of doing this presentation. If you have a tumor or a gland on top of your kidneys, adrenal gland, or a pheochromocytoma, and you would know that if you did, you cannot use this particular medicine or any glucagon for that matter. It can cause high blood pressure. Low blood sugar, GVOKE could cause low blood sugar. It's a short-acting medicine. So remember, once you get your sugar back up, you still have to start taking oral carbohydrates in to keep your sugar up until you get to more health. In rare cases, it can cause serious skin rash, and especially in people who have a tumor in their pancreas called a glucagonoma, and serious allergic reactions have happened. If that would happen for you, like a rash, difficulty breathing, low blood sugar, low blood pressure, pardon me, you need to get help immediately, which of course means calling 911. So before getting GVOKE, tell your healthcare provider about your medical conditions to make sure it's appropriate for you. It is stored at room temperature. So there's a couple ways of getting it. You can get it through pill pack, Amazon. Ask your provider to give it. I have never denied someone a prescription for glucagon if they thought they were at risk. And I think that's important for you to understand. There are copay cards. Ask your provider. There's some online. Ask for a representative. And what you're going to find is these copay cards, especially if you have insurance, are going to help you a lot. And so here's your summary slide. So just so we all know, this is one way of getting it in. This is one of the newest products on the market for glucagon administration. I hope you never have to use it, but if you do, it's a very simple, easy to use product in a situation versus the other glucagon, older style kits that are out there. Not more effective, but easier to use. Okay, now we'll do some questions. Back to you, Tammy. I'm not hearing you, Tammy. Are you muted? You're muted.
When is the expiration on these?
The expiration on it is 2 years. I always encourage people, though, to make sure that when you go and get it from the pharmacy, that you look at the expiration of the medicine they're trying to give you, because occasionally you'll find a pharmacy that doesn't use this that often. You want to make sure you get the full benefit of the 2 years, 24 months expiration from the GVOKE product.
And what's the accessibility for it and the age range on it?
So as mentioned, 2 years or older is who could use it. And then we talked about the different dosing depending on if you're less than 100 pounds or a child less than 12, you would actually take the 0.5 milligram. If you're more than 100 pounds, even if you're a child or an adult, you would take the 1 milligram. So it depends on age, and it depends on weight. And of course, if you're an adult, you would always take the higher dose. Great.
And how many GVOKE syringes would be what a doctor prescribed, for example, a 3-month supply?
So this is the kind of medicine that we would prescribe until you would come back and tell us that you needed another one. Of course, that's our key to start talking about why did you have to use the glucagon. So I usually recommend you get a 2-pack, but it really depends on your insurance. If you can get a 2-pack, I usually recommend you keep one at the most common places you're going to be at. So that usually is going to be a home and a work one, but each person is different. But if you have 2, at least you're going to have one in 2 different locations. Or the other thing is if you happen to have one that you think, you left it in the car for a couple of weeks or something, at least you still have the other one until you talk to your provider. But again, a 3-month supply would be, it's good until you use it up to that 24-month period expiration. So just remind yourself about that. And again, if you use it, make sure and tell your provider about it so that they can start talking about why you had to use it.
And a few people have asked, when is a low considered severe?
There is no definition of a sugar level. That's one of the things that was built into it because everyone is so different. And I say that not to confuse people. A severe low blood sugar means that you're unable to do the things that you would normally do in low blood sugar. So for example, if you cannot take in oral carbohydrates, no matter what your sugar is, you would be a candidate for glucagon. And in fact, there are instances, as you know of, where people in certain situations take mini dosing of glucagon. GVOKE is not currently approved for such considerations, but it is something that we talk to our patients about. That bottom line is, if you can't take an oral carbohydrate, you're a candidate. Does that mean when you're passed out? Yes. But the one that most confuses people is when they get to that point where they're a little irritable, or they're a little combative, or they're having some issues with the carbohydrate going down, those are the people we're saying inject the glucagon now, because again, in 15 minutes, we don't know exactly where that person will be. We hope that their hormones are enough to bounce their blood glucose back up. But if not, the glucagon is already on board and it's not going to hurt the person. Again, if you give the glucagon, it's not like the sugar now goes up to 300 or 400. It's going to bounce back up into the hundreds on average.
And can you see this being used in a closed loop pump system sometime in the future?
Currently, there's a lot of different research studies going on into this. I know that it is something that multiple companies are interested in. Any stable form of glucagon at room temperature could potentially be used in this particular situation. And that's something, of course, in the future, we all hope we get is a dual hormone pump. But right now, there are no approved glucagon products for dual hormone pump delivery.
All right. And I'm going to ask you one more, and then if you stay on for a few minutes after, you can turn off your video and mute yourself, but you can still go on and type an answer to some of these that you have the answer to. So
Sure.
just so you know, and everybody will see your answers. But I will ask you one more. Can you inject this through clothing?
The answer is yes. You can inject it through clothing. It is a subcutaneous needle, so we do have to be a little bit careful when we say what the clothing is. Obviously, up in Michigan, you might be a little more worried about winter coats and things like that and warmer clothes. But in the general sense of the word, yes, you could inject it through clothing as a backup. Now, of course, that's a diabetes educator type of thing that I'm telling you. It's not specific to this particular glucagon. Any injectable glucagon in general is what we're talking about. It's a general principle that us diabetes educators usually tell people.
Great, thank you.